situated. Welcome. Just give us one moment. Looks like we got a few more people on. Okay, let's go ahead and get started. Welcome again, everyone. Thanks for joining us again for this Innovations in Healthcare Learning in Action Network session. We have a great panel for you this morning. Melissa, if you could show us the agenda. Today's panel is on the adaptation and diffusion of innovations during the COVID-19 pandemic. We have an esteemed panel of experts, and of course, we'd love to hear from you on how you have adapted and infused innovations in your practice as well. So we've left plenty of time for questions and answers in interactive session. We hope this will be beneficial for everyone involved and everybody can participate. Just take a minute to go over the ground rules real quick. You should have been muted when you join the session, so if you do need to speak, you'll need to unmute your microphone. Ask that you keep your video off if you're not on the panel when not participating, but during question and answer, please by all means turn that on. Again, participate. This is meant to be interactive session, so you can raise your hand at the bottom of the chat panel, or you can turn on your video and visibly raise your hand, or just speak up so be recognized. And you can also add questions to the chat anytime. We'll be moderating those the chat channel. This session is being recorded and will be posted to the call topic on groups.io. And if you have more to say about the topic and want to connect with your peers, please keep the conversation going on this listserv afterwards. So with that, I'm going to turn it over to Diana Silimperi to introduce our panel today.
Thanks, Judd. Welcome, everyone, to the second session on adaptation, diffusion of innovation, and diffusion of innovation. We're really happy to have you here. We have an exciting panel, scintillating group, and a very pertinent topic. So I'm not going to waste a whole lot of time today with other upfront. We're going to jump right in and let the panel introduce themselves. I'd like each member to give their name, their title and organization, and then just a sentence or two about your organization's interest or specific role in innovation. So I'm going to call you by your first name, and then I'll let you go ahead and introduce yourselves. So, Karabi Acharya.
Good morning, everyone. So I'm Karabi Acharya. I work at the Robert Wood Johnson Foundation. The Robert Wood Johnson Foundation is the largest philanthropy in the United States, focused on improving health and healthcare for people living in the US. And I direct the Global Ideas for US Solutions team at RWJF, which is focused on learning from outside of the US and bringing those ideas into the US for adaptation and inspiration. Happy to be here.
Thank you, Karabi. Over to you, Matt.
Hello, everybody. Lovely to see you all again. My name is Matt Harris. I'm a clinical senior lecturer in public health medicine at Imperial College, London. I'm also the theme lead for innovation and evaluation in our NIHR Applied Research Collaborative in Northwest London and a co-director of the Masters in Public Health programme. My research interests is all about learning from low-income countries and how to adopt and adapt innovations, frugal innovations in particular, from those contexts into the NHS.
Thank you. Moving on down the line, Nowai. Nowai, great. Hope you're muted, Nowai. Unmute yourself. Nowai, hold on. Nowai, unmute. Melissa, can we, there you go, all right.
Good morning, everyone. I want to appreciate the organizer for giving me the opportunity to participate in this discussion. I'm Nowai Johnson Gray. I work with Last Mile Health as a continuing clinical education coordinator. And part of my work is to do stakeholder engagement with the Ministry of Health. I also develop multimedia content for community-based health workers and frontline health workers. I develop blended learning training materials. I also do multimedia content for community-based health workers. My organization interest is to build the capacity of community-based health workers and also support them to deliver health services to the doorstep of people that live far away from the health facility. Thank you.
Thank you very much. Shelley.
Hi, Dan. Thanks for having me here. I'm Shelley from Sevamob, and I'm the founder and CEO of Sevamob. And we provide an AI-enabled primary healthcare platform to organizations in 15 plus states of India. And now also in the US. We have also done pilots in Southern Africa. And we were named by Gartner in its list of 2019's most innovative healthcare AI companies to watch. Thanks.
Thank you. Pleasure to have you with us. And last, but by no means least, Jordan.
Hey everyone, thank you for having me. My name is Jordan Lerner. I'm based in Cape Town, South Africa, and I'm a project manager at Dimagi, a socially conscious tech company, and the creators of ComCare, which is a leading open source, offline first digital health platform that allows users to develop custom data collection and decision support applications to amplify the work done by frontline workers. And for the past few months, I've been leading our COVID-19 response work in lower middle income countries.
Well, thank you. And I think everyone participating today can see that this is a really well-suited panel with a deep experience, and I'm looking forward to hearing all of their lessons and thoughts for us about adaptation and diffusion of innovation during this horrific pandemic. We're going to have the first few questions focused for Matt and Karabi, and direct them more on organizational response to adaptation and diffusion in the context of the pandemic. Matt, if you'd be kind enough to lead off, how has the COVID-19 pandemic impacted the conceptual thinking about the adaptation of innovation, particularly your favorite frugal innovation, at the Imperial College and maybe even more broadly in the UK? And if you'd be kind enough just to share a brief explanation of frugal innovation, just so we're all on the same page.
Absolutely, yeah, thanks very much, Diana. Well, so by frugal innovation, what we mean is doing more with less for more people, essentially improving access and drawing on existing resources and repurposing them for different applications. It's synonymous with other terms such as jugaad sometimes, or good enough innovation, sometimes even bricolage as well. Essentially, the core principles of frugal innovation are about simplifying processes, issues of sustainability across the innovation pathway, working at pace, being very rapid in terms of your innovation processes, exploring how to reuse existing technologies or obsolete technologies even for a new application, potentially repurposing something from one activity into another. So essentially drawing on existing resources in an efficient and effective way. Sometimes frugal innovation, I think, is confused with being cheap, and that's not entirely the case. It's more about being affordable innovation and responding in a way that's proportionate to the crisis or the need at hand. And I think COVID-19 has been a particularly interesting case in point because, of course, it's unprecedented and so forth, and the scale and scope and depth of the crisis is so significant that we've, in multiple settings all over the world, we've had to respond very quickly. We've had to explore opportunities to innovate from other sectors, bringing innovations from other sectors and applying them into healthcare. And we've seen a lot of repurposing of existing technology into responding to COVID as well. Just some examples of that, I think. We detailed in a recent paper in Nature Medicine that looks at frugal innovation responses to COVID-19. And they include, for example, using homemade face masks instead of surgical face masks. You know, they might not be perfect, but of course they might be good enough, and of course at much lower cost if being used from, you know, old t-shirts or other cloth material. We saw in Tanzania visors being made, face visors being made from recycled plastic bottles, absolutely fit for purpose, might not be commercially sophisticated, but does the job at far lower cost. We've seen in other settings task shifting, so maybe not a technological response, more of a service delivery response, but by taking lower skilled people, perhaps, maybe not health professionals, but lay people from the community, and upskilling them slightly to be able to deal with contact tracing or testing and so forth, you're able to widen access at far lower cost than relying on expensive health professionals. And we've seen examples of that in South Korea and Nigeria, of course, particularly during the Ebola outbreak. We've seen examples of repurposing technologies. So, for example, the quite controversial use of hydroxychloroquine now, of course, was previously a treatment for malaria and other rheumatoid conditions, has been used in India at scale, actually, as a prophylaxis, not treatment for COVID-19. And just today we heard in the news here in the UK about India refitting their entire rolling stock of trains in order to become isolation bays and wards for COVID-19 patients. So thereby using, another example, using existing resources in order to innovate effectively. And there are many other examples, such as distilleries that normally produce alcohol, but pivoting to produce hand sanitizers as well. We started in the UK beginning to see some frugal innovation responses that are similar to that. So, for example, Medtronic developed a low-cost ventilator and was able to provide their source code as open source, if you like. So that was made available for free. Mercedes-Benz and UCL, another university here, made a CPAP machine in less than 100 hours. You know, so again, a good example of rapidity. And actually at Imperial College as well, we've, you may have heard in the news, developed technology that allows, through self-amplifying mRNA technology, to produce sufficient vaccine doses in just 1 litre bottle to provide about 100 million doses of vaccine at about £3 per dose. So again, an interesting example of, if you like, frugal approaches, using in that case sort of low footprint in terms of laboratory infrastructure. And that's a piece of work that's being supported by the Chan family, philanthropists through Morningside Ventures. And there are multiple other examples, I think, that illustrate this idea of frugality.
Yeah.
Where I think there are interesting questions, and I'll just end here, around the diffusion of these frugal innovations, is that this is frugal innovation is really something that we've seen a lot of in low and middle income countries for many, many years. But we don't see an awful lot of diffusion of those ideas into high income countries. There's some, but not many. And so I think that there's still an opportunity through COVID-19 to really reinforce this bi-directional learning, this flow of innovation from low to high income countries, in particular, if you might call it double loop learning, us understanding better how to innovate frugally, something that we've seen in low income settings for many, many years. So I think there's some interesting opportunities there that COVID is bringing to us.
Thank you. Well, that was actually a very complete explanation. I think is going to prompt a lot of thoughts and questions from the audience, as well as from your colleagues here on the panel. I'm going to just pick up the 3 R's. Maybe you can start talking. Here in the US, we talk about the 3 W's, to wear a mask and wait 6 feet apart. And now you can talk about the 3 R's, reuse, redeploy, and repurpose. All right. I think we want to over to you, Karabi. And I'd like you to pick up a little bit on what Matt was saying, but I'd also specifically like you, because I've heard you say this, it's really important to note what has not changed with the pandemic, as well as what obviously the pandemic has changed. And so you'd start out with some of the things that maybe, elaborate some of the things that have not changed with the pandemic, but that are still important vis-a-vis adaptation and innovation, but also then move forward to how the pandemic may have changed the conversation, even program design of adaptation and innovation at the Robert Wood Johnson Foundation.
Yeah, sure, happy to. So just because I imagine there's some folks on the call who may be less familiar with what the Robert Wood Johnson Foundation does, I'll just start by saying, RWJF has been working for over 40 years to improve health and healthcare in the United States. And central to our work, we have a vision where we believe that everyone in the United States should have the opportunity to live the healthiest life possible, right? No matter where they live, how much money they make, no matter what their circumstances, and we call that a culture of health. And we center that, that vision, if you like, of a culture of health on this notion of health equity. That, there are far too many people whose prospects for living a healthy life are limited by where they live, the color of their skin, how much money they make, etc. And so I think what has not changed is that fact, that the basic fact of health inequity. And it's almost become a cliche that, every news article I read about COVID-19 has said that, the pandemic has highlighted the inequities that have existed for a very long time. And I think my hope is that what has changed is that we're able to see it in maybe a more stark way, and that in seeing that we will have more action. I think that one of the things we have been really thinking a lot about it and working on is sort of connecting the dots. So we know that people of color and low-income people are disproportionately suffering from COVID-19 in the US. So the question is why, right? Why? So we start to kind of look back at sort of that causal chain of events. And we know that because so many of those folks have less access to healthcare, may have poorer food, may live in environments that are not conducive to living a healthy life, that leads them to develop some of these underlying health conditions, such as diabetes, hypertension, things like that. They often have less access to healthcare, and all of this puts them at higher risk for COVID-19. So in a way, that hasn't changed, but we are able to see it, I think, in a much more starker way. And part of what we've been doing at the foundation has been, in some ways, to reinforce what we have been doing for a long time, to reinforce the importance of health equity, and to reinforce the importance of the social determinants of health. But we have made some pretty significant shifts as well, with that being said. So for the first time ever, we provided $50 million in humanitarian relief. We are not sort of a disaster relief organization by any stretch, but seeing the scale of this pandemic, we felt that we had to step into that. And what we did is we focused that $50 million on 3 issues. We focused it on food, housing, and income assistance. And what that did is, first of all, it allowed us to help some people. $50 million may sound like a lot, but of course it's a drop in the bucket of what the need is. And but I think more importantly, in some ways, it helped us to change the conversation a little bit. A lot of the discussion was focused on, personal protective equipment and other kinds of sort of immediate public health response issues, which are critically important. Our effort allowed us to answer, people would ask us, why is the Health Foundation looking at food, income, and housing? And it allowed us to respond by talking about the relevance of those issues for the health outcomes that we're interested in. And so we've spent quite a bit of our response and our effort towards shifting the national conversation and recognizing those underlying conditions that are leading to the inequitable impact of the virus.
Thank you. Thank you. Well, it sounds like in particular then that the foundation is going to have its focus include issues or opportunities for both Frugal, but specifically for reverse innovation, or that bi-directional learning, and the really learning, as Matt said, of what's already been going on in many cases in many countries, in lower middle income countries. They've already had to make frugal innovation a core part of what they've done. But now the reality is countries like the United States and the UK really need to attend to, and companies like foundations like Robert Johnson attend to that, promote and catalyze it coming forward. Well, thank you both. I know you're going to have more thoughts about that, and maybe later, Matt, will come back to how we embed, how do we prepare the ecosystem to embed frugal innovation, particularly in countries like the United States. But let's turn now to the experiences of our innovators. We're going to hear from them, and then we're going to open it up to the full panel for the last part on scale. But I'd like to start with each of the innovators describing really their innovation. And then specifically the adaptations they've made during the pandemic. And I'm going to ask Shelley if you would start by describing Sevamob's kind of core innovation, and then I know the many adaptations that you've been making.
Sure. So we provide an AI-enabled healthcare platform which has three components. One is on-site pop-up clinics, second is telehealth, and third is AI-based triage and point-of-care screening for blood, vision, skin, urine, diet, and sputum. And by putting the three elements together, we are able to offer comprehensive primary care at up to 50% lower cost, where care includes everything ranging from general health to vision, dental, nutrition, cardiometabolic, infectious disease, cancer, ENT, and more. For us, it's a B2B model where our customers and employers, their schools, their NGOs, their hospitals, their pharmaceuticals, their health insurance companies, and their local government. Now, some of the tweaks which we made in the model during COVID was, one, we developed a protection kiosk called Sevamob Protector, which protects frontline health workers and can reduce the cost of PPEs by up to 90%, just because fewer PPEs are needed if you use that kiosk. Then we started offering this three options to our customers with different cost structures for each, an on-site only option, a hybrid option, and a telehealth option. Hybrid option includes some on-site stuff, and then rest of the stuff is in a telehealth scenario. And then we started offering a COVID-19 intervention to customers for prevention, assessment, testing, consultation, referrals, and tracking of the patients. So those were some of the changes which we made to our offerings for this pandemic.
Thank you. I know we can come back to some of those, but so in essence, you offered a different kind of service, that protection kiosk or a pop-up kiosk. You had different costing structures with different types of service as well as some new types of services. Is that a good synopsis?
That's correct, Diana, yes.
Thank you, Shelley. All right, excellent. Anybody else want to add? I mean, Jordan, what has Dimagi been doing?
Yeah.
Again, start with your innovation, okay? Sorry.
Sure. So to speak a little bit about our innovation, in brief, we developed a tool called ComCare. It's open source and offline first, and we build, or it allows users to build in a non-coded environment. Easy to use data collection software that can also provide decision support. And these are mobile or web-based applications that can be pushed down to the frontline level. When we thought about how to respond to COVID-19, we looked back to our experience responding to previous outbreaks, and specifically to our experience responding to Ebola in West Africa in 2014. And what we learned there is that oftentimes the best response is that which is most readily available to be stood up quickly. So with that in mind, we wanted to remove barriers of entry to use ComCare as a tool for COVID-19 response. So the first thing that we did was decide to offer pro bono access to the platform for any government or organization interested in using it. And to go along with that, we've also developed a series of free mobile and web-based template applications designed to be used at any phase of the pandemic, whether the first few cases are just beginning to trickle in, or whether an organization or government or country is at the point of recovery. All applications follow either CDC or WHO guidelines, and they offer decision-making support to guide the work at the frontline level for key interventions. So we have a lab tracking template application, a health worker training and monitoring application, facility readiness and stock tracking, a port of entry screening application, a community-based monitoring application that works over WhatsApp or SMS, but has the case management backend of CompCare. And we have a contact tracing template application that allows for the registration of confirmed and suspected cases along with their contacts. And then it facilitates follow-up and testing based on WHO guidelines. So to go along with template applications, recognizing that data collection is really only a piece of the puzzle, we built a series of template dashboards to go along with our contact tracing tools so that while users are collecting data, they can quickly draw insight from it and reshape their response efforts accordingly. And finally, through generous support of several organizations, we've been able to stand up a COVID response team and shift a large portion of our staff around the world to provide in-kind services to governments and partners who are interested in using COVID-19. So, for example, since late March, we've been working with the Togolese government to add a digital component to their contact tracing efforts. Within days of working together, we were able to stand up that contact tracing application. It's based on the WHO FFX protocol and a dashboard to help them get in front of the outbreak. And since March, obviously, a lot of things have changed. And as the situation has evolved, we've been able to work with them to adapt the template applications to their evolving needs and emerging concerns. So we've added new user types, new workflows, and several key indicators to help better reflect what's happening on the ground.
That's an amazing amount of adaptation in a very short period of time. And I was just reflecting as well on Matt's original 3 Rs. And you've really, I think, exemplified a number of them, right? In the context of the way you've adapted quickly for the pandemic, including repurposing and designing new things, but, you know, repurposing your platform for sure, your CompCare platform. Redeployment, that was a new one. I had not realized you actually had stood up a whole new task force. That's exciting to work with ministries. And then the reuse, as you've described in a number of different ways. So that example really is quite concrete and really very, very amazing. I'm looking forward to hearing a little more about that. We talked maybe about thinking about diffusion and some of the adaptations that you've made to bring your adaptations to other settings. So hold on to that thought. And Nowai, I know some of what actually was just shared by the both Shelley and Jordan are pertinent to you for Last Mile's work in Liberia and what you just shared in terms of the focus on core innovation of community health workers. But maybe you'd share with us all, when you look back on this experience, what was the most significant lesson you all learned at Last Mile's Health in terms of adaptation of your CHW innovation?
Thank you. I would say that my significant lesson learned regarding the adaptation of innovation is the continued use of mobile technology by community-based health workers. In a resource-constrained country like Liberia, the use of mobile technology is very important. I would say that it improved the effectiveness and availability of training materials and job aid. I also like to say that community health workers see mobile phone as a very powerful working tools that guide them in performing their routine services with safety and confidence in the absence of their supervisor, as well as refresher training. Like before the outbreak, I would say that Last Mile Health, working along with the Ministry of Health and digitally enhanced over 4,000 community health workers with smart mobile phone. Okay, I have some of my phone here. I don't know whether you can see it, but we're able to digitalize them with like mobile phones that were preloaded with videos. We're also able to give them the power bank that will be used to charge the phones. And then we also gave them the solar plate. Okay, so you see there's a solar plate that we gave them. So the mobile phone, as I said, were preloaded with videos, like in the area of malaria, malnutrition, immunization, diarrhea, family planning, pneumonia, and so on. So take for example, I would say that during my field visit, I observed that community health workers are using their mobile technology effectively to improve the services of care that they are providing in their community. They are also like following all of the infection prevention measures, like in response to COVID-19, by washing their hands regularly and then keeping distance away from their patients, even while providing care. So mobile phone for me is very important. Thank you.
Thank you, and I love that. I think you have just done a first on our land series with the show and tell of that. That was great to actually see some of the innovations. Thank you for doing that, Nowai. I'm going to pick up on the digital element and maybe come back a minute to both Jordan and Shelley to talk specifically on what Nowai was saying, sort of with mobile phones and the whole digital shift. How have you introduced, in some cases expand on what you said before, but either introduced or adapted telehealth digital programming in the context of the pandemic to new settings, either expanding or to new settings, including in some cases the US? Shelley, do you want to start?
Sure. So our platform already included patient data management, which could work offline in low resource settings. It also included telehealth capabilities like second opinion and embedded video consults, both from web as well as mobile. So increasingly, we have seen requests from other healthcare providers for licensing this digital element for their own services. So that has become a key part of our offering as well as revenue generation activities. The second thing is, especially as we are tweaking the business models, we are running a marketing campaign to offer telehealth as a service to these employers, especially as the compliance requirements are coming into place as employers are reopening and so on. So I would say the digital element, especially telehealth, has become very important in this post-COVID scenario. And increasingly, there are requests both for infrastructure as well as for telehealth services from different customers.
And it's actually, you've changed your business model as well, really, in that
exactly,
context.
yeah. But I will add into that telehealth alone is never the answer. You always need a hybrid option because telehealth alone can only handle so many use cases, only an address. It's more of a lead generation mechanism for most of the conditions. So that's why you need a hybrid model.
Thank you. Jordan, did you want to add anything to that?
I can speak a little bit about how we found success introducing in CommCare to new models, and I think a lot of what we've been trying to do is build tools that reflect best practices that are being put out by leading public health organizations. So what we're really seeing is that strategic response plans they're being written in real time, and many countries are following best practice and releasing protocol as put out by the CDC and WHO. So having a tool that can push these protocol to the front line, and I think I spoke to this a bit, that allows workers to learn these protocol easily in place of not having the same availability to training that they normally would. Pushing that to the frontline level and allowing workers to easily collect data that can be used for internal analysis, but then also is structured based on international standards, so it can be shared with the larger community. It can be a huge win. So for example, Sierra Leone, where CommCare has been introduced before, but never at the ministerial level, they were planning on using the WHO protocol to conduct a facility readiness assessment to see how well equipped their primary healthcare facilities were to respond to COVID-19. Knowing that we had this template application that could kind of take them 75% of the way, we were able to work with the Ministry of Health and within 24 hours, adapt that tool to their specific needs to be able to launch the application in nationwide, so in all 16 districts. And we've seen success following that same model in the United States, where Dimagi's built an SMS-based solution based on CDC guidelines now to guide contact tracers through their work and ensure that patient and contact information is collected accurately and securely. So at its core, The system is designed to map an outbreak as it's happening and facilitate contact tracing to flag cases for follow-up early on. And we've been working with various cities across the country, including San Francisco and states like Alaska, to implement this tool.
Thank you. Yes, I was very much hoping we'd be implementing it in North Carolina as well, but it's really an impressive leap that you made there. I want to pick up on a point that you made and carried into the last part of our discussion, really, which is that in many ways you've used the digital tools, building on best practices, your words to push to the front line, my words would be to really catalyze diffusion, really, of this to the front line and to the broader, in your case, in Dimagi's case, to even a broader context of another country like the US. So thank you. All of you, excellent information and experiences. Let's kind of open up the full panel now and focus these last few minutes before we open it up to the audience to the effect of the pandemic on diffusion, which we just started out, and scaling of innovation. So let's go back to Shelley for the moment and talk about how the pandemic has challenged perhaps the scale up of Sevamob's innovation and your responses to those challenges. Some you started to say, your business model adaptation, but maybe focus it now on scaling the challenges.
Sure. So during the lockdown, some of our regular interventions were on hold just because the government was not permitting those type of activities to take place. But that lockdown did present new opportunities, especially around COVID. So just in the last 2 months, we have signed 12 new contracts for different types of COVID services and actually delivered some of those services. So for example, for the state of Rajasthan in India, we are running a mobile medical unit to do COVID testing. Then we also, for example, are working with customers like Fullerton and Magma to do a prevention and campaign and awareness campaign along with sanitizer distribution in different communities on their behalf. We have worked with different other organizations like National Highway Authority of India to provide on-site employee health services in a COVID-like scenario. We just got a contract from Airport Authority of India in Guwahati to provide like those services at the airport setting. So those are just some examples of the type of contracts which came in just in the last 2 months because of new opportunities from COVID. As I mentioned earlier, we are offering these services now to employers as well as factories as the lockdown is opening. There is a compliance requirement from government around different things around COVID in those settings. And so we are at the forefront and we're running a marketing campaign both in India as well as in the US to tap that opportunity. So I would say that while our regular interventions have been on hold, COVID itself has prevented a lot of new business opportunity.
I hope that you're documenting all this, Shelley, because that's really an amazing amount of opportunity out of this, incredible, horrific pandemic, but that you have really addressed those challenges by finding, new services, new clients, even, the employers themselves, the new markets. Jordan or Nowai, how about you? Did you want to address anything more in terms of the challenges you faced for scaling your innovation and how you've responded to them during this pandemic?
Yes, I would say that the pandemic has challenged our work, mostly in the area of training. So due to the pandemic, training days now have increased. The number of participants per training session has decreased. And then the quantity of infection prevention material that we need to use during training has increased. For example, is that during our infection prevention control training, we'll have to purchase a lot of infection prevention material. Like before COVID-19, the maximum number of participants per training session was like 30 person. But due to the COVID, you only need 10 person maximum. And then if you have the number of participants like 100 that you need to train, it means that you need to divide them into various sessions, which will increase the number of days that you will spend doing training. It will also increase the number of training sessions. It will also increase the quantity of material that you need to use during the training session, because participants are not allowed to exchange material like hand sanitizer, you can't allow them to use one bottle. So you have to give each participant a bottle of hand sanitizer. And then it is very difficult to train, most especially when using the mask to talk, and then even moving between participants to see what they are doing. Also, you need to keep in mind social distancing. Even getting them to work into smaller group is another thing that we have to put stop to. So, I mean, it's really challenging, but we are getting there actually.
But again, I think it's impressive that you've addressed those challenges, and in many ways now have expanded and made more effective the training that you're doing in the context of this pandemic. Let me turn back to Matt and to pick up on something earlier he said, and to ask him to add a little bit more to that. And that's really, as we go forward, how might we think about embedding really concepts of frugal and or reverse innovation into the process of adaptation, right? So that it's more or less becomes a part of the landscape going forward. And we'd love to hear your thoughts on particular types of research that might be needed to learn more about adapting and scaling innovation from LMICs now, during and after the pandemic.
Yeah, thanks, Diana. So, I mean, I think this particular pandemic has thrown into relief, I suppose, many of the fragilities of the health systems in high-income countries, whilst at the same time demonstrating a lot of the very, I think, exciting innovations from low-income countries, and to a large extent, just how robust some of these responses have been. And whilst we've seen some significant international collaboration and efforts in terms of cross partnership and collaboration between many countries, I think we also see quite a lot of exceptionalism, and I'm talking mostly from the UK perspective, whereby we generally approaching the COVID crisis in a go it alone kind of way. Developing apps, developing technologies, developing contact tracing systems, as if there are no good lessons to learn from elsewhere. And I think that's a really missed opportunity to a large extent. And we're finding in recent news that many of these solutions that we've created ourselves are not really working very well at all in response to COVID. So with respect to the exceptionalism piece, at least what it appears to be exceptionalism, I think underpinning that is perhaps to a large extent a certain resistance to approach countries in the global south to ask for support, or at least to learn more about the innovative solutions. We've heard 3 superb solutions already, which we would, would fit from here in the UK. So I find it surprising that we're not doing that as much as we should be. And so therefore, in order to understand some of those reasons, I think we need to ask ourselves, well, what are some of these entrenched, perhaps, perceptions around innovations from the global south? To what extent are we judging them prematurely because of where they're from? There's a lot of evidence to suggest that we do treat innovations from certain contexts differently, oftentimes worse because of where they're from. And there is a bit of a legacy effect, I think, from development assistance that needs to be tackled, addressed, and talked about, so that we can have a more of an equal playing field in terms of international cooperation and collaboration. This really cuts at a lot of the sort of issues around social justice and knowledge hierarchies and what we understand to be robust evidence. It also cuts to, I think, core principles around generalizability and how we determine whether something that works well in one setting might or might not work well in another setting. But what we see in the UK, at least, is a tendency to go to, if you like, go-to countries, the US, Sweden, France, Germany, and others, at complete exclusion of the Rwandas, the Nigerias, the Ethiopias, to understand why aren't we doing what they're doing. And we see it, unfortunately, manifest in a complete neglect, if you like, of certain solutions that we uphold to be completely useful, such as the use of community health workers, such as the use of task shifting, such as the use of mobile phone technologies in the community to support decision making, we're just not doing it here. And it's almost as if there's these are innovations for that setting, but not for this setting. And so that comes across quite confusing now to the general population that are, because of the COVID crisis, seeing many of these solutions in the zeitgeist through social media and other things, and asking, why aren't we doing this? Why are we not doing this here?
So this is really an open call here to the audience on this land, because there clearly are incredible need and opportunities for reverse innovation and frugal innovation across the world, and certainly very much including highly, in theory, highly developed places, high resource countries like UK or US. We're going to turn over to the Q&A now, as I know there's lots that the audience may want to contribute as well as ask. But I will ask you each to give literally no more than 1 minute, but one sentence take-home message that you want the audience to go away with from what you said or from the panel. And Karabi, I'm going to put you on the hot spot and ask you to go first.
There's so much to say. You know, I want to echo actually a lot of what Matthew just said, and about sort of the inherent biases in how we learn globally. Country of origin bias. You know, we tend to focus on medical issues. I think that my one sentence, if I can say it, is this idea of connecting the dots and working to see how each of these innovations fits within a larger context of health and healthcare and health equity and the social determinants of health. So helping others to connect the dots among the various issues.
Excellent, thank you. Jordan.
Sure, thanks. So certainly hard to sum up in a minute, but I think one of the take-home messages that I'd want to definitely pass on, that I think everyone on this panel did a really wonderful job of illustrating, is the importance of flexibility when it comes to developing solutions for outbreak responses. Everyone has shown we've all had to be flexible, changing in real time to reflect emerging needs on the ground. And then the other take-home message that I'd share is and as a tech company, tech is not the be-all and end-all solution to outbreak response, but rather I think it's a wonderful thing to be used to assist frontline workers to increase their capacity, their quality of service provision, and to allow them to work more efficiently and be most empowered with up-to-date information and protocol.
Beautifully said. Nowai.
Okay, I would say that considering the effectiveness of mobile technology to address our challenges during training, I'm appealing to donors to invest more in mobile technology for community-based health workers, because they shoulder the health care delivery burden more by visiting family and providing healthcare services. So empowering them, I think, will address most of our primary care needs in developing countries like Liberia. Thank you.
Thank you. Shelley?
I would say that we need to live with COVID in the short to medium term. So we need to adjust our cost structures, offerings, business models accordingly. While it is challenging, but it also presents new opportunities to all of the providers on this call.
Excellent stated. And we started, so we're going to end up with Matt.
Thank you. Well, I think it's about following the examples of Sevamob and Dimagi and exploring cross-boundary and cross-border diffusion. It's to, I think, end with the message that here in high-income countries, you do have a market for your solutions, and we need to work actively and collaboratively to bring them into high-income settings as well, where we have a lot of fragility in our health systems too.
Thank you all for this excellent panel and discussion. And I'm going to turn it now over, I think, Judd and Melissa, you've been curating some of the questions. I know there's one that I would like. I'd like to hear your questions, and please identify yourself, your organization, and direct your question to a particular member of the panel if it's appropriate. And I would also, I believe that Andrea Taylor had sent something in that I want to make sure we start with her. Andrea, are you on today?
I am.
All right.
Yeah.
Would you kindly just share a little bit about the framework for adaptation that you've been working on in GHIC and IAH?
Yeah, sure, absolutely. So I'll go through this really rapidly, but if anyone is interested, please contact me. And you can contact me through any of the contacts you have at IAH or GHIC, and it can get to me. We are developing a framework for the process of adapting innovations into new contexts and new markets. So that includes both sort of frugal innovations and innovations moving from the global south to more high-income countries, but also south to south and north to north, etc. So we are looking with this framework at the different kind of the essential tasks and the common challenges at each stage in the process of adapting. And we're looking at it by stakeholder as well. So for innovators, the innovative organization, for the adopting health system, for the policymakers, et cetera, in that context. And I'm quite interested in getting feedback and input from all of you in terms of what that process has been like that you've observed in your own experience, but also thinking about how is it different. I'm quite interested in some of the things that have been mentioned today in terms of how it's different now in the midst of the pandemic that we are experiencing. And I think I think Jordan, you mentioned that actually tracking to sort of recognized guidelines like CDC or WHO recommendations for the pandemic has been quite helpful, a really helpful piece of getting innovations, diffusing innovations out into either new innovations or into new places. And I wonder if there are other lessons like that that have been learned during this pandemic. So I will leave it there, but we are in the midst of putting this framework together. We're beta testing it now. We would love feedback and input. If anyone is interested in seeing it, commenting on it, I would be very grateful and can share it with you. We hope to have it published by the end of the summer.
Thanks very much, Andrea, and hopefully folks will take you up on that. Melissa, I believe there was another question that had come in earlier, but I'm going to turn over to you and Judd now to see if there are any particular responses or questions. I didn't see any in the chat, but maybe you have been getting them.
Yeah, I have one. They were wondering how to institutionalize the good behaviors during the COVID-19 pandemic to urban slums, such as washing your hands and different sanitation practices.
Maybe Nowai can begin to address a little bit of that. Maybe not necessarily in the slums, but maybe just institutionalizing those kind of behaviors, but open it up to anyone on the panel.
Okay, thank you. Firstly, I would say that in order to institutionalize good behavior, you will firstly need to work along with the Ministry of Health. Get them to buy your idea. And then you will have to develop protocol by working along with them. Create awareness to inform the general public about the advantages and disadvantages of hand washing or sanitation. And then the next step is also working directly with the community-based health worker to see how best you can get them to be trained in proper hand washing so that they can be the one to disseminate your idea. So with that, you will also need to generate funds. So you need to work along with the stakeholders in the community, see how best you can generate funds to purchase hand washing materials, as well as working along with them to set up a monitoring team that will be able to monitor the entire process. I don't know whether I answered your question correctly.
Thank you.
Can I just chime in on that question?
Yes, please do.
You know, I think one of the things that we have been talking a lot about and trying to emphasize here in the United States and from the RWJF perspective is that, you can't ask people to do things that they are unable to do, that they're incapable of doing because of their circumstances. So for example, you know, we ask people to call their doctor. Well, you know, many Americans don't have their own doctor. We ask people to self-isolate at home. Many people in the US are living in fairly crowded conditions and don't have a separate room in their home where they can isolate someone. A lot of the public health guidance that we're giving to people is often just not feasible, particularly for lower income folks. And I think that, I think one of the things that is so incredible about the innovations that tend to come from low and middle income countries is that they often are designed for the most vulnerable people in society. And too often, I think we forget that in higher income countries, that innovations do need to be designed for the most vulnerable people to be able to take advantage of them. And so that's just sort of a general thought on that relates to the hand washing question.
I agree with Karabi that, for example, we have been running prevention campaign in urban slums as well as in rural. But for example, in slums, while we can do the prevention awareness, we can distribute sanitizers, we can distribute masks. There is no way to enforce social distancing in that setting. It's just not going to work.
No, that's right. I mean, that is certainly one of the major issues, right? You cannot rebuild a slum overnight. And then it's not just really the dense urban squatters or slum settlements, as Karabi, you said, there are many families in the United States that are living multi-generational sometimes and a large number of people in a small dwelling. So, and that is just the economic reality for many folks. All right, let me just see, is there any other, just do a quick check, because if not, I have some other thoughts here before we close with the panel, but we certainly are interested if anyone has a question or if anyone in the audience would have something they would like to share from their own experience of adaptation, their innovation during this pandemic. Okay, do a little bit of a hold here. Now I see a number of folks on here that I know usually speak up, so I think the panel has just so exquisitely addressed many of these issues and with very concrete examples. It was really excellent. Okay, I'm going to ask Karabi then just to perhaps finish up here, but given what we've been hearing today on the panel and the amazing innovations, adaptations, diffusion, scaling, all through the challenges of the pandemic, how has this influenced your thinking? And what might you carry forward to RWJF, particularly in terms of, you know, using some of this innovation from other countries, from LMICs, the reverse innovation concept in the US going forward? How might it affect you personally? Nothing like putting you on the spot, but in the context of the discussion today. Thanks, Karabi.
Thank you, and thanks for such a great discussion. You know, I think that, you know, one of the silver linings of this horrific and tragic pandemic is that suddenly everyone is learning across borders. Right, that everyone, you know, I have never seen so much coverage in the US media about, you know, what South Korea is doing or what China is doing. And people have all kinds of opinions about these things. And so that's very encouraging. I mean, to Matthew's point earlier, I'm not seeing as much about what Liberia is doing or Rwanda is doing. There is a country of origin bias in that learning, but I'm hopeful that there is an opening there for particularly Americans to understand the value of learning from other countries and contexts. I think that my hope is that learning, which to date has been primarily in the more epidemiological and clinical space, my hope is that we can include learning across countries around the social determinants space. You know, what are you know, are other countries handling income assistance? For example, Ghana has a very innovative program around that. How are other countries dealing with the issue of childcare, with housing, you know, some of these other issues? My hope is that we can expand our global learning in that perspective. And I think that, you know, I think the last point I'll make is that so many, so many of these frugal innovations, if you like, are really, you know, I think of them more as resilient innovations and innovations that are in many ways designed for diffusion, because they tend to be simpler. They tend to be much more adaptable because they are designed in resource constrained environments. And I think there's tremendous hope on that front in terms of thinking about how do you design for diffusion. So thank you so much.
Thank you. That was a wonderful closing for us all. I'm going to thank the panelists. Deep appreciation to each of you for all the work you're doing and your participation today. Fabulous discussion. I'm going to turn it back over to Jed. We're going to put up the last slide. Melissa, if you will do that, and Jed will close the session.
Thank you, Diana, and thank you, Karabi, Matt, Nowai, Shelley, and Jordan for your excellent contribution and the panel. Everyone in the audience, please submit proposal for initiatives to land to address, panel discussions, things that we can collaborate around. We would love your input. You can reply directly to Melissa for the invitation. You can put it in the chat session here, or you can email any of us here at Innovations in Healthcare. The next session, that's actually July 8th, is on workforce development and remote training. I think that actually came up here. I think Jordan mentioned it about you know, scaling your workforce in the context of COVID-19 to deploy more things. So we're going to talk about tools, and we're going to have a great panel put together for that. I hope you can join us again July 8th. And we'll also have coming up is a talk about our curated evidence-based index coming out that we're gathering all these tools that you guys are mentioning and finding more and the evidence behind them, so everybody has a common reference for them, and we'll be presenting those out in the future. Thanks everyone again for tuning in, and we look forward to hearing from you in a couple of weeks and in the meantime online. Take care everyone and stay safe.
Thank you all.
Thank you.